Welcome to How Does a Global Pandemic Reshape Health IT panel discussion. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get into it, I want to take care of a few items for those listening in. First off, this panel discussion is being recorded and will be available to you for future viewing. Throughout the Q&A, all attendees will be in listen-only mode, so if you have any questions for any of our panelists, please type them into the questions section on your GoToWebinar console, and we'll get to them after the discussion. So today we have four of my colleagues from IMO. Our moderator is Rob Wallace. He's our Chief Product Officer here. Rob has run product management in Fortune 50 companies and has been a founding member of several venture capital-backed technology startups. He is a product visionary and has amassed more than 36 patents and technologies around automated drug dispensing, indoor GPS, and hand hygiene. And then in no particular order, I'll go into our panelists. So for starters, our Chief Medical Officer, Dr. Andrew Cantor, is an internist and a global health specialist. He's been with IMO since 1994, and in 2006, he joined Columbia University in the Department of Biomedical Informatics Epidemiology, and is a member on the board of Global Health for the National Academy of Science, Engineering, and Medicine. And then we have Lori Kevin, who is our VP of Enterprise IT and Security. Lori has over 20 years of experience in IT, from customer support to data center management and cloud operations. And she focuses on an underlying security and enterprise application support. Lori is currently leading IMO's business continuity task force to stay up to date on local and national workforce place health and safety guidelines to dynamically update policy and site guidelines for IMO's workforce. And last but not least, we have Sahas Submaranian, and he has been with IMO since last spring. He has an extensive background in the technology space, and Sahas is driving the architecture and architecture and engineering culture here at IMO. He's very passionate about complex challenges with adoption and implementation of healthcare standards and information systems. So with all of that being said, I'm going to pass it over to Rob Wallace.
Thanks, Jordan, and welcome everybody. As you know, COVID-19 has affected every facet of life and industry as we know it. And our business, Health IT, is no exception. In today's discussion, we're going to talk about how this pandemic has not only impacted us as a health IT company, but how it has perhaps magnified the importance of some issues, including interoperability and telehealth. This is mainly to keep up with the demands of the increased sharing, right? As many of us go remote, increased data sharing and reporting. In addition to interoperability and telehealth, is playing a pivotal role in providing and treating patients at what's considered now a safer distance. And it very likely, the truth is, these changes to our industry were already going to happen, and there were some early indicators. And it seems that COVID-19 is accelerating these trends. So with that, I'll dip into a little bit. We'll talk about our agility as a business, the COVID-19, our IMO response. A little bit about IMO. We've been in the health IT industry, particularly in the clinical terminology space, for over 25 years. In that time, the medical community has seen other global outbreaks such as Ebola, Zika, H1N1, and we've been able to use our experience to inform our efforts to address the needs for COVID-19. And with the panelists here, I want to talk to each of you about how IMO leveraged our past experience to address the changing needs of the healthcare industry within this pandemic. And Andy, my first question is going to be for you. What did we learn from past global outbreaks that helped IMO respond quickly to COVID-19?
Thanks, Rob. I guess probably one of the very first things that we learned, particularly around the Zika outbreak, was that it was essential for the terminology, the information systems, to be capable of actually capturing what was going on at the beginning of these outbreaks. So IMO, for example, had been kind of observing what was going on with Zika in South America, and we were aware of some of the unusual complications, particularly the maternal complications of the disease. And so we really made sure that there was a very specific, clinically friendly and appropriate terminology available in the health information systems. And so we pushed it out to just about all of the US. And so, even prior to the first actual case occurring in the United States, which I think might have happened in Hackensack, New Jersey, they had that information in their information systems so that when that first patient actually showed up, the clinician was able to actually search, find Zika or microencephalopathy due to Zika, and be able to document that and therefore capture important information about the epidemic. I think the other thing that we've learned a lot about is that these require a lot of change in our systems, and vendors and health information system providers and providers themselves need to be prepared for all the changes that are associated with the disease. And so, in Zika, it was initially, again, that the manifestations of the disease were showing up not just for the patients themselves, but for the children who were eventually born of those pregnant women. And with COVID, it was initially all about capturing the information about, travel history and other types of exposures, and then became much more about what are the symptoms and potential complications of the disease. So we have to be really quite nimble about that. And maybe the other really important part is that as the government bodies and the standards bodies sort of get awareness of these pandemics as they come out, there's a lot of changes that go on with the information systems themselves, the codes and the standards, and that this often will happen quite rapidly over the course of the pandemic. And there can be many changes, whether it's in how you document the codes associated with the disease itself, or now as we're anticipating that vaccines are about to come out, it's like which vaccines are going to be there, how are we going to document those in the system too? So all of these changes are all happening really rapidly. And it's one of the key aspects that we learned from this is how to be prepared.
Oh, thank you, Andy. I wonder if you could double click into the clinical need for the accurate documentation, patient identification, interoperability as well for us.
Sure. I mean, I think, as I mentioned, things about changing during the epidemic, I think our information requirements definitely changed over the course of the pandemic. And so when you think about it, at the very beginning, when this was just happening in March, at least in the United States, information was really about regulatory reporting. Are these patients actually happening? Are there cases in the United States? How bad is it? How many people are being infected? And so a lot of the focus was initially on kind of the regulatory and official case report. Then it really very quickly became a concern about, do we have the resources to respond to this pandemic? And that was a focus really on things like, do we have beds? Do we have isolation rooms? Are there enough ventilators? Do we even have enough doctors to treat the patients that we are expecting? And so a lot of the focus on the information being captured at that point and being able to pull that information centrally was around resources. Then once we realized that the curve was starting to flatten and that we were not going to be totally overwhelmed, the focus really became on treatment. What's really working and what's not working for patients. The fact that we learned that patients who shouldn't probably be as intubated as quickly as we thought, or perhaps they would do better if they were put on in a prone position when they're breathing. Understanding all of these kinds of aspects of care were really the next phase. And then most recently, it's a lot about the actual new therapeutics that are happening, whether it's remdesivir or convalescent plasma, being able to capture that information about the patients and the characteristics of the patients to understand what works and what doesn't work. And then finally, as the vaccines start to get rolled out, what is it that is the need? Who needs to be vaccinated? What is the appropriate vaccination? Are we actually vaccinating the way we're supposed to? And then, of course, is that vaccine being as protective as we think? So if we look at this whole process, having really specific, accurate information changes across the time of the pandemic, but never goes away. It's really essential that we have that information to make decisions.
Great, thank you. Thank you, Andy. Hey, Sahas, my next question's for you. How did IMO pivot our product offering to address the needs of our clients at this time?
Thanks, Rob. We know we have to be agile and nimble. COVID-19 really helped us to push that agenda forward. IMO started doing off-cycle releases to keep up with off-cycle code sets, updates that are happening. Each release requires immense amount of testing and validation to keep up with content quality. So since COVID, we did 4 off-cycle releases, 1 problem, and 3 procedure related releases. A lot of the content updates were surrounding around procedures, and line code had most number of updates to do. The second aspect related to it is we also open sourced COVID-19 problem and procedure products, so anybody can go leverage it. Also, the same way we open sourced COVID-19 precision sets for those who want to build some analytics and insights, using our content.
Thank you, Sahas. Hey, Lori, next question's for you. The pandemic has impacted how we go to work, right? And let's call it, maybe call it a hybrid model at IMO. Could you tell us how IMO has shifted to this hybrid working model?
Yeah, thanks, Rob. I certainly can. As you can kind of see, even on the panel, we're sort of representing that hybrid model right now, right? We've got a couple of folks actually on site in our Rosemont facilities and a couple working remotely. So we're hearing a lot of that concept, right? That word thrown around, the hybrid workplace. So we're really trying to define what that means for IMO, and organizations in general really need to work with the appropriate team members to understand what it means for them. So we're kind of looking at it conceptually as you are no longer an on-site employee, but you're also no longer a remote employee. So for now, you may have those needs to remain working remotely due to things happening that would prevent you from coming on site. But there could in the future be intentional gatherings, ceremonies, sessions, etc., that are best served in person, that work better with a team, that you can agree upon to determine if that's something that you can try to achieve in the future. So there's a ton of considerations to shift to this new approach that we're walking through, and certainly some lessons learned for us to think about from an organizational perspective. So to help define this for us, we assembled our business continuity team, of which Adi and I are both members, along with other members of people and culture. And our punch list was a number of things you can imagine at the beginning of March and now continuing on through current day. That's a variety of areas that we need to cover. So what are employee needs? What are the equipment needs when on-site is not an option? What remote best practices can we provide for the organization? How do we communicate that? How do we share it? And what are the resources that we can continue to provide to our workforce to make sure they have what they need? How can we foster that collaboration, right? The water cooler talk, the stops at grabbing a cup of coffee. How can we help to foster that and encourage teams to reach out? So we've created kind of channels and sub-channels that are both tactical in getting the work done, but also for posting pics at home. We have a channel called Critter Connection, right? Where we have a lot of fun seeing other people's pets and the types of activities that they're going through at home. We're providing a centralized enterprise customer center so that we can make sure that there is a one-stop shop for people to go to get all of that information. Analytics are also really important. So we're trying to identify the measures that are important for us to track. So looking at the visits that we do have on sites, being able to schedule time to actually come on site. And not only that, it's regardless of where you're at, how are you spending your time? Is it in meetings? Is it on Zoom calls? What do we need to do to help facilitate continuing to be productive? And then making sure, again, back to the tool sets and resources that we're providing that effectively. And then on the facilities side, that was a lot of work for us. So we worked very hard to understand the types of things and measures we need to have in place to welcome our employees back should they choose to come back on site in the safest and most secure way. So increased signage, formal scheduling system to track those on site, some alerts that helps us to identify if someone came on site and perhaps needs a change in location to ensure social distancing, providing PPE and increased sanitation. So those are the types of considerations that are really, really important to make sure that you can support that hybrid workplace. So at the foundation of this is we're really focused on the most important aspect being the human one, right? So everyone knows it's a challenge right now. We're working remotely, juggling maybe less than perfect, working conditions and equipment at home, supporting e-learning for kids as we venture back in school. So it's all really difficult. So for us, we also really have a focus on working with our managers to check in with them, and then providing those managers the appropriate resources to work with their people to make sure that we have that ability to support this flexible work schedule and coach through any of the challenges that anyone on the workforce are facing.
Thank you. Yeah. Hey guys, we're going to shift gears a little bit here. Let's talk interoperability. With the shift to value-based care, we know that providers and companies that support them are more focused on improving patient outcomes through several facets, including quality improvement, as well as population health initiatives. Frankly, as a result of the need for these comprehensive, actionable analytics, right, they're becoming increasingly more important. And I'm reminded by a quick story by Wayne Keithley, who was president and COO of Mount Sinai, when I heard him tell the story. And it's really stuck with me since I think I heard it about 2012, 2011. Wayne always had a way to explain the complex very simply, right? And I'll paraphrase his story here. You see, he would tell the story, and you'd put two hotels across the street from each other, and you'd find they operate a lot alike. Reservations, housekeeping, food service, etc. Right? They work a lot alike. And then he'd give the example of put two hospitals across the street from each other, and you'd find that they operate very differently, right? Even to how the patient data might be collected, right, and presented and rolled up. So the goal, right, of CMS interoperability and patient access rule is to expand the access to health information, to improve the exchange, right, in healthcare, and to enable better coordination, right, to improve the patient outcomes and frankly to reduce costs as well. So sort of getting to my question here, I'm sorry, due to the pandemic, CMS will not enforce this rule, right? We understand it's July 1st, 2021. However, the need for capturing, sharing, and reporting on the COVID-19 data in particular has made interoperability more important than ever. So Andy, apologies for the long preamble, but could you click into how COVID-19 is impacting interoperability efforts for us?
Sure, Rob. The rule that you mentioned is kind of ironic that the president was going to announce it at the HIMSS convention, which ultimately was canceled at the start of this pandemic in the United States anyway. And that 21st Century Cures Act, on which that rule was based, really mandated two main areas of change. There was a further sort of expansion of the technical aspects of interoperability, making sure that software itself was able to communicate with other software applications across different kinds of barriers in a way that the meaning was not being lost. But it also included information that helped remove the blocking efforts that were happening that prevented people's health information from actually being transferred between facilities, for example. So at the time that this was all happening, the information blocking rules were pretty much ready to go into place. They were relatively fast acting, but the technical ones, the technical interoperability rules were basically an extension of what was happening already with meaningful use. There was a more gradual approach to sort of getting systems to work together. But when COVID hit, it was sort of like putting all of these things on steroids, because suddenly it was no longer just this sort of hypothetical need to actually move data around. It was actually a physical, tangible need. And it wasn't just about moving data from, when I move an EHR between one hospital and another hospital. It was like, now I had to be able to figure out, how am I going to get the data out of the parking lot where people are actually coming through to be tested for COVID, just across into the emergency department or into the hospitals itself. So interoperability became a real requirement. And so many of the standards that were initially envisioned by the 21st Century Cures Act were absolutely applicable and needed to be accelerated quite a bit. The other part that was really kind of important was that, there was an unbelievable outpouring of collaboration amongst providers and scientists to try to solve this problem. And this was maybe one of the first pandemics that actually happened in this truly interconnected world. And so suddenly there were these coalitions of researchers who were coming together globally, if not just in the United States, who really wanted to act on the data to try to figure out what was working and what's not working, what we could predict about this pandemic and how can we fix it. And so the need to actually move that data around was really important. I was lucky to participate in two of them. One, the COVID-19 Healthcare Consortium, which has like 800 different partners, many different EHR vendors and data aggregators all working together. The other one was the N3C Collaborative, where it's more of an academic group. But essentially, they're taking this data and they're bringing this data out of their where it sits at rest in the facilities and actually together examining it. And so interoperability was absolutely essential if we were actually going to be able to do that, because we didn't want to lose what knowledge, what experience was being captured out there while everyone was working in overdrive during the pandemic.
I have a quick follow-on for you, Andy, with that. So could you share a little more around the data sharing's increase within the health system, right? And how it helps us respond to the pandemic. You talked about the getting it out of the parking lot, or getting it into the parking lot and then back into the facility.
Yeah.
How much further does that reach go?
Yeah, it's a lot more than even what Sahas was talking about in terms of just like even having the right codes in the system between the two systems. It's much more about understanding how that information is going to be used and how it's recorded and is it really fit for purpose. And when we look at the pandemic, you can use the same kind of maybe lens on it, that you can look at the global side, and the very first thing that data does is help us, from a regulatory reporting point of view, actually understand the epidemic. And so WHO, CDC, now the HHS are all, essentially requiring us to update them all about what's happening with the pandemic. And so that kind of regulatory requirement is one big sphere of use. I think we start to pull back a little bit to our facilities and look at sort of population health. And again, this is where we're starting to look at who's going to do worse with this disease, who might be doing better, what kind of treatments are appropriate for which types of patient populations. And so pop health is certainly benefiting from data sharing across outside of just the EHR or the individual patient's record. More and more patient registries are involved, and this is going to be really key when we start to talk about some of the vaccine therapies. As we know, many of the vaccines that are coming out, and we're just recently been notified by the administration that we can expect them, perhaps one or two of them by the November or toward the end of the year. We have to be able to figure out exactly who is supposed to get those vaccines. So registering those patients, understanding whether or not they've had one shot, because they're most likely going to need two several weeks apart, really is going to require us to have this sort of global and patient-centric view of the information, so that we can make sure that the people who are needing the treatment are getting it and are appropriately vaccinated. And then perhaps as a provider, one of the most important things actually is that I just have the information that I need to take care of this patient right now. And so making sure that the appropriate history is available. So, whether the patient gets their lab test done in the parking lot or in my hospital or the CVS, how do I know what the results of that information are when I'm seeing them in the clinic? If that patient tends to worsen and they need to be admitted to the hospital, how does that information get into the hospital? And then how does this information from other patients who are in similar situations come to me, so that I can better make decisions about the appropriate treatments and learning from those outcomes. So we can look at this from the global, large-scale public health regulatory reporting view, or all the way down to individual patient care. It's really important that all that information is captured at the highest level of specificity, and that we retain that information to make better care.
Andy, thank you. Hey, Sahas, next question's for you. Andy's helped us walk through some of the why, right, and the real need. could you unpack for us, what infrastructure do hospitals need to have in place to achieve that vision, right? To help us effectively share data.
Sure. Thanks, Andy, for great, setup. I think, like Andy said, all those use cases we're experiencing them right now and looking forward. So for effective data sharing, I think a couple of aspects are interoperability and data normalization are key to success. What do I mean by normalization, right? Typically, hospitals have data sets representing various aspects, right? Patient chart, encounters, diagnosis, procedures, labs, medication, on and on. And would want to normalize the data to something common so that they can run analytics, generate various insights such as patient cohorts that Andy mentioned about. So we suggest clinical data normalization should be at the highest level of granularity for WIN. So as an example, right, we help our customers to achieve this standardization using a product called IMO Precision Normalize. And that doesn't really require any additional infrastructure on the customer side. The heavy lifting happens on the IMO side, and by following common standards such as FHIR, we make the data interoperable. So, in short, prepare to handle large volume, secured data exchange. We cannot take security off of our site, and demand seamless interoperability from the vendors who provide software systems. So that the hospitals are enabled to use best-in-class solutions across the spectrum and serve patients better.
All right, thank you, Sahas. So Lori, Sahas talked about security. Let's unpack that a little bit more. We're moving a lot of data around. We're sharing data. Could you unpack for us what are some of the security concerns with all of this increased data sharing?
Sure, thanks, Rob. There are plenty. As I think we're really highlighting, data is going to be key here, right? So as we are seeing movement of sensitive data, confidential information, we really have to make sure that the systems that are in place to transmit it, to store it, are secure. There's right now no shortage of threats, right, or attempts to access this data, and that protected health information is just so extremely attractive, right, to hackers or to malicious figures. There are hacking attempts that may be done directly into environments. There's phishing attempts that are, right, those social engineering type activities to get you to click on the link, and now suddenly they're inside. And so having the right measures in place to detect that, and first to prevent it, but secondly to detect it and respond, is really critical. So the key is really in establishing, communicating to your organization and then reviewing periodically what we're calling organizational controls, which are really those processes and procedures that are focused on key areas, which is overall security, availability. So none of this really matters, right, if the system's down. So making sure there's redundancy in place to effectively be on all the time. Data integrity. So I think Andy did a great job of really highlighting the importance of the data from a reporting and analytics perspective. That's going to be key to helping us really make some meaningful decisions, and certainly for the providers to act in real time. So making sure that data is of quality and accurate and complete. And then certainly the confidentiality. So making sure that all of that data is protected so that there is nothing accessible. So it's from an organizational perspective, having that kind of those four key components in mind. I'll just kind of give some examples of the different considerations that you should have, right, within your list of items to check off. Is there an understanding of that data flow within the org and those sensitive data access points? Where's the data coming in? Where's it going back out? How's it getting shared? What are any integration points with third-party vendors? And how do we secure those? What are the vendor management measures that you have in place to make sure that they are secure, that they have availability standards in their, in their processes as well? Access management is a major consideration. So always making sure you're deferring to least privilege, which means anyone who has access needs to have a business justification, right, for their role or their job function to have that access, and making sure you're putting in the right review procedures so that there is a review with those authorized users to make sure that they still need the access. onboarding and offboarding, right, is a big step in making sure that enabled access is enabled and then immediately revoked upon a termination or some sort of a change in the overall role. From a design perspective, you know, we're working with Sahas quite frequently as well as our software engineers to align on those security considerations. So are we using kind of the optimal security services that our cloud provider may offer? Do we need to build something in-house to better manage that? You know, Rob, we're working with you as well in your product org to make sure that we have those types of requirements really understood at the start of the design of that idea inception, right? Making sure that throughout the life cycle of what it is that we're doing or promoting, that we're meeting those high standards of security. From a workforce perspective, I think there's a lot of things that you can do, which are pretty basic and standard things worth mentioning, right? Which is education and awareness training is critical, making sure that that is done upon joining the organization and annually thereafter. Coming up with these types of phishing campaigns to kind of test the workforce, find out where you may have some vulnerabilities, where specific individuals may need some additional testing, but making them aware of the types of attacks that could happen, and making sure that they understand their responsibility to prevent it. Scans are done across workstations and continuously running to address any critical vulnerabilities that may be found. So I think it kind of ties in with all of the data management that we now have, and with all of that sharing across the board, the security considerations and really review of those controls are critical.
Great, thank you, Lori. I see that website data is beautiful, and they talk about the data breaches, and it's I'm always surprised at frankly who's in that website. So thank you for that. Yeah, hey guys, let's shift gears again and let's talk about telehealth. We know telehealth has been around for the last few decades. Oddly enough, I had a startup in the late 90s called Telepharmacy. So it's, we could say telehealth isn't new. However, what's something we have seen is during this pandemic, we're seeing physicians and other health professionals today seeing 50 to 175 times the number of patients via telehealth than they did before the pandemic. I think this is largely in part due to patients wanting to avoid COVID-19 exposure, and also how the payers and the reimbursement is affecting telehealth. We know that even after the COVID-19 vaccine, telehealth could well or will remain a standard of care. How does the telehealth industry, how does it need to evolve, right? How do we need to adapt to really increase this telehealth usage? And so Andy, I'll stack on that and ask you the first question. How has telehealth changed our provider experience?
It's ironic, Rob, again, that, just a few months ago, I think I was doing a webinar about clinician burnout and how providers didn't want to be in front of the computer anymore, and then how much they hated the health information systems they had to use, and now they're entirely behind the computer. So we can anticipate that there's going to be a lot more time behind the computer, and some of those things that were bothering them before will certainly bother them even more now. And so, on one side, it's going to put additional pressure on clinicians to be able to interact with the computer and with the patients remotely in ways that they might never have had to do or very minimally had to do in the past. But also that there's going to be just increased burden on documentation, because there's going to be as these new sort of billing and codes come into place. To be able to actually characterize these telehealth visits, there's going to be a lot more focus on documentation. But as a provider, I think one of the other things that you realize is that without actually having the patient sitting there in front of you, a lot of those clinical cues that you would have before that would work at sort of at a subliminal level in your brain aren't necessarily going to happen. And that it's going to be really essential that information about the patient is being provided to you in that screen, which may be the same screen you're looking at, or maybe next door to the screen you're looking at where the patient is, into actually giving you that global picture of what's happening on the patient. Sahas talked about the nature of the terminology and why it's really critical that the record or the data that's being collected captures the clinical intent that the provider had. It might not have been me that saw the patient last time, so I better be able to figure out what's going on with that patient relatively quickly from this online experience so that I can still treat the patients and do that in a way that doesn't burn me out faster than I was being burned out prior to this all happening.
Great. Thank you.
Just I think for the benefits of audience, I'm going to repeat the question as much as I understood and try to tack on it.
Right.
So how do we provide, how can a provider organization help their EHR workflows or help their staff with EHR workflows, even with remote visit situations? So I'm going to kind of hone in on the same two bullets that Andy started off, right? It's like one is reduce the burden around documentation and reduce the burnout. So towards the reducing the burden on documentation, right? Provide systems to ensure that the right codes on patient charts are available. The codes are accurate and most up to date, and they are quick. They're able to interact with systems, fast, so that it enables the staff to spend more time with the patient rather than spending time on the system. And also on the reimbursement workflow perspective, enable accurate reporting and care documentation across the continuum of care to maximize the reimbursements and improve the accuracy of the EHR systems, right? So I think it goes back to our conversations earlier. It's we need to rely on the best-in-class technology with security and confidentiality in mind at the same time. Enable, focus on these aspects. Enable fast, accurate, and most up-to-date codes to reduce the documentation burden on all the areas.
Thank you, Sahas. Andy, I'm going to double down on that for just a moment. How does telehealth support the patient engagement strategies in healthcare organizations?
I think, Rob, you mentioned it earlier. I mean, I think there really was no engagement prior to this when healthcare was essentially shut down and patients were feeling quite uncomfortable about coming into the healthcare system. So I think having this as an option has dramatically improved the relationships between the patients and the health systems. I think it gives the patients a certainly more safety, confidence approach to being able to get answers to their questions. But I think it also, in many ways, brings patients and their providers closer together because they're now interacting it doesn't seem like quite as big a leap for those patients to reach out to a healthcare provider when it's done through telehealth. And given what Lori and Sahas have mentioned about what sort of we've been doing, the fact that our life is very different now as a provider of technology. We're living in this hybrid world. Much of our work is being done remotely. There's a lot of telecommuting going on. I think this is going to be the new normal in many situations. And, it's hard to predict when this is, quote unquote, going to end and whether the vaccinations is going to really make that much difference in the short run. I think for the foreseeable future, and particularly for people who are at particularly high risk, they're going to need tools like telehealth encounters to maintain their preventative care, maintaining their relationships with their providers. And so the activities that the regulatory bodies and the health systems and the health information system providers have all had to make to bring this up to speed a lot faster than we originally thought are all going to go to good use, and I think will be likely used for the foreseeable future.
Excellent. I hope so. So kind of what stacking onto that, what is the outlook of telehealth, right? As that standard of care?
Yeah, I mean, I think looking at, there was a recent McKinsey report that sort of asked, first of all, whether providers were used to this and kind of whether what was their feelings toward telehealth now, and 6 out of 10 of those providers said that this was favorable. This was, the downsides of this hadn't quite yet come up, perhaps, but they were feeling much more positive about telehealth than they might have been prior to this. The amount of services that can be provided remotely has expanded, and that CMS has, essentially approved about 80 new services that could be reimbursed for via telehealth. So this doesn't have to be a financial constraint for health systems to be able to provide information remotely to patients. And from a business point of view, you just take a look at that Teladoc Livongo merger that was priced at something like $38 billion. That the business community is definitely looking at this in the long run. So we'll definitely be living with telehealth, I think. And as we do so, we're going to learn a lot more about what works and what doesn't work with these types of encounters.
It's almost like the future is arriving now.
Cool. Absolutely.
Lori, again, with telehealth, right, with remote data, can you walk us through and help us unpack some of the privacy and security considerations?
Yeah, I mean, I think that really it goes back to those controls I mentioned, right? Because even myself as a potential user of telehealth, I want to make sure that that the provider does have those same controls in place, right? What are the measures that we can put in place to protect that? It's the collection, it's the use, it's the disclosure of all of that sensitive personal information. Because at the end of the day, that's really going to affect not only the patients, but the clinicians, right? Level of trust and willingness to adopt and use it. So it really goes back to the focus of protecting all of that, certainly from a patient perspective, but again, those clinicians are feeling that same responsibility right now that they're venturing into this new way of having to interact with their patients. So a lot of that it goes back to those 4 principles to know that the system that is in place is protecting that exchange and that interaction through every step of the way.
Great, thank you. So, guys, I think I'll do a quick wrap up here. To conclude, we've talked a little bit about the business agility, right? The agility of a business. We've talked a little bit about interoperability and telehealth. Some of the examples around our agility as a team and a business. It's who would have guessed, right, that we'd be working, taking classes, talking to our doctors over Zoom, Skype, and GoToMeeting. The interoperability, or said another way, the ability of a health information systems, as Andy was talking about, to work together within and across boundaries. Our industry was going through a number of functional and structural changes that Lori and Sahas talked about, as well as, of course, my favorite, semantic models like IMO, right? That interoperability change has been a powerful wave in the industry, and it will continue. And then telehealth, right? Sort of near and dear to my heart, probably about 20 or so patents in that area. But they're old at this point, back in the late 90s. Is it a fad or is it the future? And I'm with Andy. I think it's probably is our future, right? It's likely to become our modern day house call. My guess is it is the future. I have a 80-year-old mother in Seattle with multiple comorbidities, and she isn't a big fan of all of this, but she's sure willing to give it a try. And I think if she's willing to give it a try, it has a pretty powerful future for us. So I think, Jordan, with that, we can go to some Q&A, and I can see that we have some questions have come up while we were talking. So guys, I'll throw it out to you, and pick it up if you'd like the question. What advice would you give a hospital IT department that is strategically planning their resources for the future? Who'd like to take that?
Rob, I can take that one, I think. Again, I go back to those 4 principles: the security, availability, data integrity, confidentiality, and really privacy, right? So those fundamentals are really what should drive the plan. So one thing that I think is worth mentioning is the importance and necessity of a risk assessment, right? So making sure that you have the right participants across your organization. So members from people in culture to information security, enterprise IT, software engineering, product, finance and legal, right? Other compliance organizations. Making sure that as an organization, you're able to kind of identify those high risk events that may impact your business. So it really takes a look at the likelihood of an event and crosses that with the impact of that event and what that would have on your organization. So from there, it kind of spits out this prioritized list that you can start with the highest, right? And then come up with the plans to mitigate that. So there's some things too that help to establish then what your risk appetite is. Some things you can say this is a high risk and here's how we've mitigated it, right? It goes back to those controls that are in place to address the potential for that risk to actually occur. And then you can work your way down that. Again, having that cross collaboration and that interdepartment touch point is really critical to identify those things that are going to most likely impact your organization, and then come up with the secure and come up with the really complete plan to go and address those. And that's something that should actually be done by establishing the plan and then certainly periodic review thereafter.
Great, thank you, Lori. I'm glad we have you watching our backs. Another question has come in. Gang, call the jump ball if you want it. At a time when we are more physically distant from each other rather than ever before, and talking about the telehealth, what can we do as an industry to humanize the patient interactions within these new remote environments?
Well, maybe I can talk about that because I think the patient-doctor relationship in some ways is a microcosm of a lot of the other dynamics that are going on right now with us being separated from each other physically, if not emotionally. And so, I think one of the challenges that we have is how can we make these interactions as effective as possible? And what does it really mean to be in relationship with each other, or to have human to human kind of interactions? And we used to say that the doctor will see you now. What that usually meant was the doctor would actually have you walk in the office, and they would then turn their back to you as they were working on the computer while you sat there and answered their questions. Now we have yes, we will see you. I'm seeing you on the screen right now, all the 4 of you distant, but am I actually seeing you? And the answer is probably not really, especially if I'm dealing with patients who are hurt or unwell and are really in the time of need. How do we make those interactions as meaningful as possible? And part of that is to be seen more than just physically, and that is to actually have your information understood by your provider. How can that information be captured, presented, integrated to the provider's workflow so that it's seamless to the provider, and so that the provider, when I'm talking to you across the screen, you feel like I really know what's going on with you. And at least I understand what your problem is. I might not know why you have that particular problem. Let's work out how to solve that together. But how that information gets presented, how I interact with the information systems that are sort of supporting or augmenting me as a provider are really critical. And so the way we start to deal with this this physical separation needs to be more than purely I'm just looking at you. It's about understanding your problem. It's about how do we communicate, how do we use the information systems to communicate more effectively. So to me, it's a really important question going forward, because it's not just about patient doctor relationships, but as we go into a digital future and where many of our interactions are going to be like this, is like, how do we keep that human component there as we're interacting through a digital means?
Yeah, the future is arriving. Jordan, at this point, like to turn it back over to you to close us out.
Yeah, thanks, Rob. And thank you all your panelists for speaking today. Before we close out, I wanted to share that we have an upcoming webinar on September 17th at 12 p.m. Central. This will be a comprehensive webinar on the ICD-10-CM 2021 code updates, in which our top coding professionals here will review additions, deletions, and other revisions to the code set. So I am putting the link to sign up into the chat box that you should all get. And don't worry if you're busy that day, sign up for it and we'll send you the recording after the webinar. With all of this being said, we're going to go ahead and close out for today. If you have any questions or want more information about IMO or our solutions, please contact your IMO client executive or email sales@imo-online.com. Thank you again for attending, and please stay safe out there.